Hello, my name is Shany Welsh, and this is the presentation of my project, Increased Cultural Education for Emergency Department Staff, in partial fulfillment of the requirements for the degree of Doctor of Nursing Practice. Thank you to the committee members of this project, including my DNP Chair, Dr. Moyer, the Community Support Person, Shannon Pazowicz, and 707 Second Reader, Dr. Stroyer. Cultural competence is defined as a sensitivity to the unique experiences of individuals from different cultural, ethnic, and racial backgrounds. This is a crucial aspect of healthcare delivery, but has been found to be lacking among healthcare workers. To increase this level of cultural competence among healthcare workers, evidence suggests incorporating cultural education for staff. Low levels of cultural competency are noted to be associated with poorer patient outcomes and satisfaction. Patients with limited English proficiency, or LEP, have been found to have additional barriers to healthcare access with implications such as miscommunication, reduced patient satisfaction, decreased quality of healthcare and safety, increased healthcare costs, not seeking treatment when needed, and increased length of treatment. 22.5% of the total U.S. population speak a language other than English at home. In the county of this project, it's 29.9%. Diverse patient populations, especially those with limited English proficiency, face several challenges to achieve health equity. Thus, as healthcare workers, it is imperative to address these language and cultural barriers and work towards breaking them down by increasing cultural competence. The primary aims of this project are to increase the cultural competency level among triage nurses, as seen in an increase in the cultural competency checklist scores, improve the triage process of patients with limited English proficiency, as seen in an increase in the emergency severity index scores, and lastly, to promote health equity for diverse patient populations, specifically those with limited English proficiency. The PICO question that arises from this is, in nursing staff at an emergency department, does an educational intervention on culture compared to current practices improve nurses' cultural competence level and the emergency severity index scores for patients of limited English proficiency post as compared to pre-intervention? There is vast evidence that supports the need for cultural education to improve cultural competency in healthcare and its impact on patient outcomes. To further categorize the evidence, the literature was grouped into three themes: language and cultural barriers in healthcare, cultural competence as an intervention, and improving patient outcomes and ESI scores. Language and cultural barriers. The U.S. has a large immigrant population, leading to significant healthcare barriers, particularly from language and cultural differences, with limited English proficiency being a major obstacle. The ED is a key entry point into the U.S. healthcare system and a primary source of health disparities. The triage system, though standardized, is susceptible to biases based on race, culture, and language. Racial and language barriers impact both patient and nurse satisfaction. Studies show non-white patients are often assigned lower acuity ESI scores and fewer diagnostic interventions than white patients. Even with similar ESI scores, non-white patients are prioritized less and receive less intensive treatment than white patients, leading to delays in care. Cultural, racial, and language differences in the ED create significant barriers to quality healthcare, risking missed triage and delayed treatment due to biases or lack of cultural competence. Cultural competence as an intervention. Improving cultural competence can help address disparities in healthcare by addressing how cultural and social factors affect health beliefs and behaviors. It involves recognizing personal biases, learning about cultural norms, and developing skills to work effectively with diverse patient populations. This can lead to stronger advocacy for vulnerable groups. The first step in promoting cultural competence in emergency medicine is through cultural education and training, which helps reduce cultural dissonance, improves communication, and leads to better clinical outcomes. In the fast-paced triage process, Nurses may overlook the need for language assistance or cultural understanding, which can affect patient care. Properly identifying a patient's language proficiency and providing the right support can improve communication, ensure accurate triage, and ultimately lead to better patient care and outcomes. Improving patient outcomes and emergency severity index scores. ESI scores are influenced by factors assessed by the triage nurse, and race and culture significantly impact a nurse's perception of a patient's acuity, altering the ESI score. These variable scores affect treatment and rooming priorities. Mistriage and variable ESI scores stem from factors like language differences, cultural beliefs, race, ethnicity, symptom presentation, and nurse bias. Recognizing these disparities is the first step in improving cultural competence, which can then be applied to reduce mistriage for diverse populations. One study found 32.2% of ED encounters were mistriaged, with non-white patients at greater risk. Non-English speaking patients were less likely to receive higher ESI scores, leading to longer waits, lower prioritization, and less intense treatment. The care gap between non-white or non-English speaking patients and their white counterparts directly impacts healthcare inequalities. These disparities can harm health outcomes, underscoring the need for cultural humility among healthcare staff to better care for diverse patient populations and improve health outcomes. The theoretical framework that is most representative of this DNP scholarly project is Lewin's change model. This model involves 3 steps to make a successful change: unfreeze, change, and refreeze. The first step, according to Lewin, is to disrupt the current method. In this project, the unfreezing occurred by providing pre-education cultural competency checklists to triage nurses to assess their baseline knowledge. This data helped identify existing gaps in cultural competence, motivating nurses to improve. A chart review of patients with limited English proficiency also assessed the impact of cultural competency on initial triage assessments. The second step involved implementing the changes. For this project, cultural education was introduced to the nurses, who were now aware of their cultural knowledge gaps and motivated to adopt the new information. The final step is to sustain the changes. This involved reviewing the project findings to demonstrate the positive impact of increased cultural education on nurse perceptions and patient encounters. While the scholar initiated this step, full execution extends beyond the project itself. This project used a quantitative exploratory method to determine whether the intervention was effective and statistically significant. This is the primary methodology for this project because it aims to measure the effects of the intervention on specific outcomes without randomization. The project involves cultural education that is not routinely provided to ED nurses and a cultural competency checklist to assess the level of cultural competence among the nurses' pre- and post-educational intervention. In addition, the project involved a retrospective chart review to collect ESI scores for patients with LEP before and after educational intervention. The data collected from the checklist and the ESI scores were compared pre- and post-intervention to determine if the educational intervention had a statistically significant impact on the scores. Before this project, there has been no cultural education or cultural competency assessments for ED nurses. This project used the checklist scores and ESI scores to determine the effectiveness of cultural education for nurses. The focus of this project is multifaceted, involving the cultural competency of ED nurses, but more significantly, the impact that may have on the triage process of patients with limited English proficiency. The DNP Scholarly Project was conducted at a private hospital in the Midwest region of the United States. ED triage nurses and the electronic medical records of patients with limited English proficiency presenting to this ED were targeted for this project. Specific inclusion and exclusion criteria were utilized to ensure that participants were qualified to be involved in this project. The sample for this project included 37 ED nurse checklists pre- and post-intervention. and 234 ESI scores of patients with limited English proficiency pre-intervention, and 245 ESI scores post-intervention. Descriptive statistics summarize the data collected, which included cultural competency checklist scores from triage nurses and ESI scores for patients with limited English proficiency before and after the educational intervention. This project used a quantitative exploratory design, collecting data through retrospective chart and survey review to assess the impact of cultural education on nurse competency based on checklist scores and ESI scores of patients with limited English proficiency. Because the checklist data was from the same sample of triage nurses, an independent samples t-test was considered, but certain assumptions must be met to use this. In this case, the assumption is that the dependent variable, the checklist scores, must be normally distributed. The Kolmogorov-Smirnov and Shapiro-Wilk normality tests showed the checklist scores did not meet the normality assumption. So a Mann-Whitney U-test was used to compare pre- and post-intervention of checklist and ESI scores. Variability was measured by range and standard deviation. For the checklist, the pre-intervention scores ranged from 39 to 63 with a standard deviation of 6.229, and post-intervention ranged from 44 to 64 with a standard deviation of 6.694, showing a slight increase. For ESI scores, pre-intervention scores ranged from 2 to 5 with a standard deviation of 0.593, and post-intervention scores ranged from 2 to 5 with a standard deviation of 0.692, showing consistency. The larger ESI sample size allowed for a better measurement of variability compared to the smaller checklist sample. The difference between pre- and post-intervention checklist scores was found to be statistically significant. Z equals negative 3.221 and P equals 0.001. The checklist score data analysis demonstrates sufficient evidence to suggest that the intervention achieved the goal of improving post-intervention scores. However, the difference between pre- and post-intervention ESI scores was not statistically significant. Z equals negative 0.243, P equals 0.808. The ESI score data lacked significance. Therefore, it did not demonstrate sufficient evidence to indicate that the intervention increased the ESI scores of patients with limited English proficiency. A key limitation was the ESI score data, which was pulled from the electronic medical record report function. This method assumed that the documentation, including the patient's preferred language, was accurate. However, registration staff who input this information may not have cultural training, leading to potential inaccuracies in language documentation. Another limitation was that not all staff attended the mandatory staff meetings, so some nurses who received cultural education did not assess every patient post-intervention. This could affect the data as some ESI scores were not compared with pre-intervention scores. Despite these limitations, the project was successfully implemented and yielded valid results. The primary finding of this quantitative quality improvement project demonstrated that cultural education provided to triage staff does have a statistically significant increase in cultural competency levels. When comparing this project to the studies in current literature, there is ample evidence suggesting that cultural education can improve healthcare providers' cultural competency levels. Secondarily, the project also assessed the ESI scores of patients with limited English proficiency and compared pre-education and post-education scores to determine if there would be a change in ESI score. But this project did not provide sufficient evidence to have a statistically significant difference between pre- and post-intervention ESI score. The studies in current literature do not directly coincide with this project, but there is evidence that demonstrates that the care received by diverse patients, including those with limited English proficiency, is different from those who are not. Strengths of this project include its retrospective design, which was ideal for evaluating the educational intervention and integrating it into mandatory staff meetings, increasing participation. Recognizing the need for cultural education and the potential impact on diverse patient care was another strength. Rigorous data collection and inclusion criteria also enhanced the validity and reliability of the results. The findings are generalizable beyond triage nurses and patients with limited English proficiency. The project's focus on cultural education can benefit a broader group of healthcare providers and patients of various races and ethnicities in different settings, such as ambulatory and inpatient care. Sustainability of this project is high due to the clear need for cultural competence in this facility, as shown by the project's results. To ensure lasting change, cultural education could be integrated into the onboarding process, though ongoing analysis of ESI data may not be sustainable without further evidence showing its change with education. Cultural education improved triage staff's cultural competency level. Recognizing personal biases, learning cultural norms, and developing skills for engagement are crucial. The results align with other studies showing that improving cultural competence can reduce healthcare disparities. While the project showed no clear evidence that increased cultural competence raised ESI scores for patients with limited English proficiency, the literature supports that cultural competence can reduce disparities and barriers that these patients face, including during triage. In terms of implications for future research, the data clearly indicates a substantial improvement in cultural competency levels after cultural education, thus implying the need for further evidence-based strategies to implement such practice changes and increase the cultural competence level among healthcare workers. Healthcare leaders and policymakers must address the disparities faced by diverse patient populations. While this project doesn't provide new evidence, it supports existing literature on the importance of cultural education to improve care quality for these patient groups. Stronger efforts are needed to advance related policies in the current political climate. Quality and safety have always been a priority and are the cornerstones of healthcare. This project focused on the quality of care received by patients with limited English proficiency and indirectly discussed its impact on their safety. It addressed the inequities in healthcare and the broader implications of patient-centered care. To ensure diverse patient populations are receiving top quality and safe care, it is vital to increase cultural competence among healthcare workers. The project highlights the need for cultural education to improve the level of cultural competence and foster more inclusive care for patients with limited English proficiency. In doing so, the quality and safety of care provided to these patient populations will ultimately dull their health inequities. This project addressed a major flaw in healthcare: inequities of diverse patient populations and the lack of cultural competence among healthcare staff. The project aimed to address these issues by improving cultural competence among emergency department triage staff. The intervention involved pre- and post-cultural competency checklists and assessment of emergency severity index scores for patients with limited English proficiency. It showed a significant improvement in cultural competence post-education. However, no direct correlation was found between cultural competence and higher emergency severity index scores. Despite this, the project laid the groundwork for more inclusive, patient-centered care. This project provides the basis in addressing the needs of the U.S. healthcare system. In a country so diverse, it is imperative that staff have some level of cultural competence to adequately care for diverse patient populations. Furthermore, these diverse patient populations, especially those with limited English proficiency, are countlessly overlooked and deserve a push for health equity. Personally, the DNP project has equipped me with the skills and knowledge to advocate for health equity and drive systemic change. While I would adjust some methods of this project, such as expanding staff participation and exploring additional variables influencing ESI scores, This project has sparked meaningful conversations about cultural competence and health disparities. Moving forward, I plan to continue promoting cultural competence in healthcare and push for policy changes to ensure health equity for diverse patients. Here are all of the references used for this project. Thank you so much for listening.